Dr. Givrad is a perinatal and infant psychiatrist and assistant professor in clinical psychiatry at Weill Cornell Medicine. She is the director of maternal infant psychiatry program at Weill and the perinatal infant psychiatry fellowship program. She has expertise in treating psychiatric disorders during pregnancy and the postpartum period, and works with families of infants with young children in parent-infant psychotherapy when families face issues of attachment, bonding, medical traumas, or other regulatory disorders in infancy. Academically, she's been working on bridging increased attention to psychiatric disorders during pregnancy and postpartum to increase awareness, of course, of this really critically important time to jump in and support women or birthing people. And she is also aiming at increasing training opportunities. So it is really my pleasure to welcome Dr. Givrad to the Barnard Center guest lecture series. So I'll turn it over to you.
Thank you. Thank you, Dr. Oxford. I am going to try to share my screen, and I'm very happy to be here with you all today. All right. Can you all see the presentation mode? Okay.
Yeah.
All right. So hi, everyone. It's an honor to be here with you today and to talk about a topic that I believe is very important. As Dr. Oxford mentioned, I'm a perinatal and infant psychiatrist at Weill Cornell, and a main focus of my career has been on providing training opportunities for clinicians and services for infants and parents in the Neonatal Intensive Care Unit, or NICU, and post-discharge from the NICU. I have no actual or potential conflicts of interest in relationship to this presentation, and I'd like to take a moment to acknowledge that while we traditionally talk about NICU interventions for moms and dads, we know that families are built in a variety of ways, and I strive to use inclusive language in our discussion today. All right, so if you're here today, I gather you care about and are aware of the critical importance of infant and early childhood mental health. But why do we need to care about the mental health of infants that have to go to the NICU? Well, it turns out that they make up to close to 10% of all live birth. And with all the advances in neonatology, we have seen increased rates of survival of very premature or extremely premature infants who are born as early as 23 weeks of gestation. We also know that those infants and their families face many challenging outcomes, including having medical and physical vulnerabilities and socio-emotional and developmental issues. Let's take a moment and think about these infants and their parents. So they face early separation, and their early life is in an unnatural environment where different rules are in place. They face early life stress and pain, and their parents face uncertainty and a whole range of complex medical information they need to digest and make sense of. Many NICU infants are less responsive, and they use different cues compared to full-term healthy infants. Their parents experience significantly higher rates of depression, anxiety, post-traumatic stress disorder, and other psychological distress. And eventually, they might face increased difficulties academically and psychosocially. That all said, I do want to emphasize and remember that NICU infants and parents make up a very diverse group of infants and parents in terms of medical, psychological, and perinatal risk factors. For example, infants who are born less than 28 weeks gestation often have a much longer and bumpier course in the NICU, or having a baby in the NICU might lead to more severe distress in a parent with a history of trauma who does not have a good support system, or who has to take care of other children, or is struggling with no parental leave and financial insecurity. But as a group, they're very vulnerable, and we need to find ways to better support them. So I want to go back to one of the most commonly used definitions of infant mental health, which is the young child's capacity to experience, regulate, and express emotions, form close and secure relationships, explore the environment, and learn. All of these capacities will be best accomplished within the context of the caregiving environment that includes family, community, and cultural expectations for young children. Developing these capacities is synonymous with healthy social and emotional development. Today, I would like to emphasize the context of the caregiving environment and use that as a framework for this talk. I want to acknowledge that each of the areas I discussed today can be its own separate talk or series of talks, and I won't be able to delve into each very deeply. All right. So what are the different components that make the caregiving environment for NICU infants? As we know, the parent-infant relationship is one of the most immediate and important environments in which the infants develop. The parent-infant relationship provides for infants' safety, basic needs, and survival. Parents help regulate their baby physiologically and emotionally. They create a buffer for pain, stress, and trauma, and it is within this relationship and a result of a child's experience in this relationship that they develop their internal working models or blueprints of how the world works, what to expect in the relationships, their sense of self. Now, let's look at the challenges and barriers NICU infants and parents face in forming an optimal bond or relationship early on. So, birth of a premature or medically ill baby often means an immediate and at times a prolonged separation between the parent and the infant. At this point in the field of perinatal and infant mental health, we have plenty of evidence from animal and human studies and observations that being separated from parents have negative and at times long-lasting effects on the child. In the NICU population, we know that increased opportunities for visiting and physical contact with the infant results in better neurodevelopmental outcomes for the child and better socio-emotional outcomes. But there are many potential barriers for these parents and babies to be together. The degree of prematurity or medical issues in some babies makes it impossible for parents simply to hold them, or for those who can safely do containment touch or kangaroo care, they might need a lot of help or guidance and support from the NICU team to do so. Many NICUs do not have comfortable and private areas for parents to stay with their baby for longer periods of time. And in reality, many parents either have other children or people they care for. They might have long commutes or limited or no time off from work. Some parents decide to go back to work while their baby's in the NICU to save their time off for when the baby is discharged home. So as you see, there is a need for interventions at many levels, including a NICU environment that's inviting and comfortable for parents to spend more time at the bedside, systemic protocols of how to help parents with the appropriate level of touch or holding of their infant. Do want to emphasize this cannot be left to each nurse or NICU team member based on their availability and bandwidth, and there is a need to have these systemic protocols of how to do this in our NICUs. And finally, psychosocial and case management help to support parents being present in the NICU, and at a higher level, changes in policies that give parents time off from work to be with their babies. Now let's look at the relationship itself. So broadly, one of the ways I like to look at the parent-infant relationship is that it is made of two parts: the unobservable parts, or the representations, emotions and thoughts, and the observable parts, or the interactions. What are parental representations? Many of you might be familiar with them. So these are ways in which the parent makes sense of their infant and who they are, and the ways in which they make sense of themselves as a parent and how they understand and make sense of their relationship with their child. These representations are a product of many factors in the parent's life, such as their own experiences in their main caregiving relationships, their life experiences, traumas, their beliefs, worries, wishes, hopes, culture. And they're important as they influence how the parent interacts with their child and how they make meaning of their child's cues and behavior and respond to them. We think that birth of a premature or medically vulnerable child is a stressful and at times traumatic event, and therefore can affect parental representations. In addition, NICU parents often face challenges in taking on the role of the main caretaker, which can further affect their representations of themselves as parents. So, how can you probe the parents' representations? Here I bring up examples of a couple of ways to do so. There are some interviews that we can use. One of them is the clinical interview for parents of high-risk infants, or CLIP. CLIP is a semi-structured interview that's useful as both a detection tool for parents in psychological distress and as a working through process of the difficult experiences that they had with their premature infant. This interview allows parents to emotionally consolidate their experiences of having a baby with high-risk status. So CLIP asks parents about the infant's current condition, their pregnancy, labor and delivery, their relationship with their baby, their feelings as a parent, relationship with the NICU staff and environment, their social support, and their thoughts and expectations for the post-discharge period. The other interview used to probe parental representations is the working model of the child interview, or WMCI, which asks parents to describe their emotional reactions during pregnancy, asks them to describe the infant's personality and development, characteristics of their relationship with the infant, perceived and anticipated difficulties with the infant characteristics, reactions to infant's behavior or distress in variety of contexts, and the anticipated difficulties in later development. So based on the responses to these questions, they categorize parents' mental representation into three kind of broad categories. One is the balanced, one is distorted, and one is disengaged. Narratives like responses to questions that are coherent, they're kind of richly elaborate, they're warm, affectionate, mindful, responsive to the child's needs and individuality, put the parent in the balanced representation category. But the disengaged category is seen by parents whose narrative is emotionally distant and minimizes their child's affective experiences and their individuality or their need for dependency. And finally, the distorted category. These are narratives that are more confusing. They're anxiously overwhelmed by their children's status and need. They're self-involved or insensitive to infant as an individual, or expect the infant to act in ways that's pleasing or easier for the parent. So why do we care about this? Because balanced representations are associated with better child outcomes. And there's some research showing that NICU parents might have higher rates of disengaged or distorted representations. And if you remember, we talked about how representations can affect the quality of the relationship and interactions with the child. So in a clinical setting, you don't need to necessarily be trained in conducting either CLIP or WMCI. You can use them as a framework and simply probe parents' representations by asking open-ended questions like, tell me about your child. How connected do you feel to your child? How has the experience of parenthood been for you? In what ways was it similar to what you thought? In what ways is it different from what you had imagined? What do you think your relationship with your child will be like? What are your concerns for your child? What are your concerns about your role as a parent? So you can kind of see that there are ways that you can basically like ask about the representations without necessarily following, you know, a kind of a semi-structured interview. As we're talking about parental representation, I do want to mention the vulnerable child syndrome, which is related to when parents perceive their children as being extra vulnerable, weak, or fragile. So the idea is that parental trauma due to premature birth, NICU admission, or infant's medical problems, or at times life-threatening events can lead to post-traumatic stress disorder and intrusive thoughts and fears about the child's well-being. If you remember, parents in the NICU face a lot of uncertainty and difficult to interpret information and signals. And so they might sometimes start worrying about any signal or any minor issue and worry about the worst case scenario. They can have thoughts like something bad will happen to my baby, or my child is weak and fragile. And for those of you who clinically work with this population, we know that a lot of times they can have unreasonable feelings of guilt, shame, or a sense of responsibility that in some way their child's prematurity or medical vulnerabilities is their fault. So all of these feelings and thoughts can lead to overprotective and anxious attitudes and parenting behavior, which then in turn causes problems with the child's development, their sense of self, and their preoccupation with their health and vulnerability. Can also worsen parental psychological distress. So here, just review what we have on this slide. Parents' experiences of medical vulnerability or life-threatening events for the child leads them to have higher parental perception of child vulnerability. That leads them to have more overprotective and anxious parenting style, and as a result, negatively affect their child's development and sense of self. All right, so we've talked some about the representations. Now, what can we do in terms of intervention? The first step that we already discussed is kind of assessing and understanding these perceptions and representations. And remember, like we talked about, there are three parts to that. There are the representations and perceptions of the infant. There are perceptions and representations of oneself as a parent. And then there are representations of the relationship. Once we have a sense of these and kind of their perceived sense of vulnerability of the child also, then in treatment, we can work on cognitive restructuring of these distorted, disengaged, or unbalanced mental representations, or like kind of extreme perceptions of vulnerability for the child. One thing that can be very helpful for these parents is to educate them about the infant's sensory and relational capabilities, because a lot of times it's harder to detect in premature or medically vulnerable infants kind of their resilience or strength or their capacities. And so a lot of the programs kind of use some components of parents' education to be able to see their child in a more comprehensive way. We can also explore how previous trauma or relational difficulties affect their current representations of their infant and themselves. And I do want to emphasize that the NICU staff can play a very important role, both positively and negatively, in the parental representations of their infant and themselves as a parent. So these could be even like small comments that can make the parent kind of see their baby in a new way or feel better and more competent about themselves, or comments that might undermine those views. All right, so now let's talk about the observable part of the parent-infant relationship or their interactions. This is a very intimate relationship, as we all know, and there's a significant nonverbal component to this relationship. These include touch, vocalizations, gaze, affective tone of each partner, the exchange between them, and the level of responsiveness of parent or infant while interacting. I also like to review two main concepts here, just to refresh our memory. First one is parental sensitivity, which is a parent's ability to perceive and infer the meaning behind her or his infant's behavioral signals and to respond to them promptly and appropriately. And the second one is the concept of co-regulation, which means parents and infants are in a constant state of regulating each other, both emotionally and physiologically. Younger infants rely more heavily on their caregivers to regulate themselves, and NICU infants have lower capacities for self-regulation and become more stressed and overwhelmed more easily. So parents and infants engage in this ongoing interactive dance, right, which has been shown to play an important role in the infant's development and the quality of the parent-infant relationship. NICU parents and infants face some barriers in establishing this interactive dance. Premature babies are often less interactive compared to full-term babies. They're less alert. A lot of times they might be sedated. They might use different ways of communicating their distress or needs. And so all of this can make it very difficult for the parent to read their baby's cues and get an interactive feedback from the baby. As a result, they might withdraw and be less engaged, or alternatively, they might become more controlling and intrusive in their interactions with the baby. Though I do want to acknowledge there's an interesting debate on whether in a full-term healthy baby and their parent, what we view as a more intrusive style of interaction, whether that's in fact as detrimental when thinking about premature babies, or whether there's some developmental benefits that the parent is more engaged and kind of pulls the baby out. I think we still need to better understand that. So there are a lot of opportunities for intervention here. The more basic one, again, is educating the parent on the nonverbal language of preterm babies to help them observe their baby, become curious in understanding their baby's cues, and essentially to improve their sensitivity. We can also help them appreciate the importance of nonverbal communications. A lot of parents don't necessarily know that. The positive effects of their touch, their voice, when they're talking, reading a book, gently singing to their baby, that these all have a lot of positive effects on both the relationship, but on the baby's development as well. And many of the formalized interventions use some variation of these principles to help improve the parent-infant relationship. As we're talking about the interactions, I would like to briefly go over a very important set of activities and interventions that promote the NICU infant's development. These are the family-centered developmental care practices. And these are a set of practices that heavily involve parents to decrease infants' stress and pain and promote their sensory development. So NICU infants are subjected to an environment with, as you can imagine, bright lights, a lot of noise, procedures, tests. All of these can cause pain and stress. And to add to that, they're neurologically premature and more vulnerable. And a lot of times they do not have the buffering presence of their parents to help them with their stress and pain. On average, they experience up to 17 painful experiences daily. And all of this pain and stress might have negative effects on their neuroendocrine development and developmental outcomes. So in addition to the appropriate use of analgesics, parental voice exposure or music, kangaroo care, holding, rocking, infant massage, breastfeeding, oral glucose solutions can help decrease pain. Most or all of these can be provided by parents, which, as we will discuss soon, can help them feel more competent in their role. It's also important to think about modifying the NICU environment, kind of what we talked about, light and noises and all of that, as much as possible, and work on clustering the care to decrease the frequency of pain and stress the babies experience. I'm just going to very briefly review some of the ways to provide the infant with appropriate sensory experiences. So some of these is positive touch, which is kind of gentle, non-stroking touch, skin-to-skin care or kangaroo care, infant massage. As you can see here, these all have kind of neurodevelopmental benefits. They can positively affect breastfeeding or feeding tolerance. They can help with cardiorespiratory stability. They can help with bonding. Exposure to language, parental voice, reading books and music are other ways of providing NICU infants with appropriate sensory experiences. And I do want to again emphasize that in order for all of our babies and parents to benefit from these, ideally there needs to be a system in place of how to deliver these, how to help parents, like let's say do kangaroo care, because otherwise we have research that shows that some parents get more of that and more support and time for touch or kangaroo care, and some parents don't do that. And a lot of times these fall along the lines of, you know, higher resources or lower resource or kind of racial inequalities or things like that. So again, these all needs to be thoughtfully kind of planned out as how to deliver these and how to help parents do these. All right, so becoming a parent involves a psychological transition, and a part of that transition is about how competent and confident the parent feels in their role. We call this parental self-efficacy, and there's evidence that parental self-efficacy is associated with parental competence, lower stress and anxiety level in parents, higher quality of parenting and engagement in infants' care, better bonding with their infant, and better outcomes for child's adjustment and development. But many NICU parents struggle to gain self-efficacy, and they don't always feel confident in their role as a parent. In fact, this is one of probably the more common complaints that we hear when clinically working with these parents. So what can we do to help them? There are many ways of thinking about this, but I think a way that resonates with me is like there are 4 ways of improving parental self-efficacy. So first one is mastery experience. This basically means having parents do tasks to gain mastery. For example, taking care of the baby, learning about the baby, interactions with their baby. And as they keep doing that, they feel like kind of more confident about doing it themselves. The second way is vicarious experience. So this is basically watching others take care of their baby, like nurses and the NICU staff, and kind of learning from that and eventually being then able to go to do that themselves. Another important part of that is social persuasion. This is extremely important in the NICU, as many of these parents need encouragement and help from the NICU staff to become more engaged and gain mastery. There are times that, there's so many things, the baby's hooked up to so many things, or like they touch the baby and something on a monitor starts like going off, an alarm or something. And so there needs to be a lot of like emotional support and kind of, encouragement for them to be able to do this and not to fear that they're hurting their baby. And to be able to do all of this, of course, it really helps if the person is physiologically and emotionally in a good, balanced state. So this would be like more of ways of helping parents feel more grounded, feel calmer, do self-care, like get rest, things like that. These give us a lot of ideas about interventions. So again, kind of NICU staff can encourage and guide parents in safe ways to take care of their baby's need. They can allow parents to do things and, if needed, give them suggestions and help them do it in more correct ways. Interventions aiming at decreasing mental and physical stress allow the parents to be in a state that they can take on the parental role more effectively. So again, there's kind of, a lot of ways that staff on a daily basis can help parents with gaining more self-efficacy. And so we can't discuss infants' caretaking environment without discussing parental psychological health or distress. The negative effects of parental psychological distress, such as anxiety, depression, PTSD, substance use, on the quality of their relationship and interactions with their infant, and all aspects of infant's development are shown in numerous studies, and we see that daily in our clinical work. When it comes to the NICU parents' psychological distress, there are two main aspects that I would like to emphasize. The first one is that preterm and neurodevelopmentally vulnerable infants might be more sensitive to both negative and positive environmental factors. And two, that NICU parents suffer from extremely high rates of psychological distress. So I've put some numbers on this slide. Depending on the population, that you're looking at, the resources, both in the NICU and outside of the NICU, the infant and perinatal risk factors, both medically and psychiatrically, and psychosocial factors, there's a kind of wide variation in reported numbers. But as you can see, kind of the estimates are really high. And to give you a comparison of how high these numbers are, so I think at any given point, if you look at the general population, non-perinatal, non-NICU, about 7% of people suffer from depression, right? When we look at the perinatal period, this is including the premature population, but the general perinatal period, pregnant and postpartum, these numbers go somewhere between 10 to 20% for depression, right? So they double or sometimes triple, depending again on the population. Now, if we look at the NICU population for depression, these numbers can go up to 40% or above, and that's just the depression, right? We're also thinking about really high levels of anxiety really high levels of acute stress disorder and very high levels of postpartum, PTSD for these parents. So you can see that we're dealing with parents who are dealing with a lot of psychological distress. And at the same time, it's very hard for them to focus on their own psychological state because a lot of their focus and attention is on their baby and what's going on for their baby. Some of the risk factors for depression in this population is perceived lack of support from the nursing staff, younger gestational age, which is often also associated with prolonged hospitalization, and of course, the severity of infants' medical status. So here I've put some of the ways that in this instance, maternal psychological distress can affect their interactive patterns with the infant and disturb the representations of the infant. So you can kind of see that depending on what's going on, they might become either less sensitive or more intrusive or have distorted representations of the infant and the relationship with the infant. There's less research on the psychological distress of fathers and non-birthing parents, but we do know that they also suffer from higher rates of psychological distress and can negatively affect both themselves, their relationship with their baby. And a lot of times what we see in the NICU is these kind of like stressful times, and dealing with all of these emotional issues can negatively affect the relationship within the couple. So we are not able, this has been proven by studies, we're not able to pick up on the individual's psychological distress, on everyone's psychological distress, if we do not systematically screen for that. And so systematic screening for depression, anxiety, and PTSD is very essential to actually know who is suffering and who needs more help and support. And then once we identify that, we need to be able to provide them with appropriate support and treatment. And this can take on many different forms and shapes, right? This could be individual sessions at bedside. This could be group psychotherapy or group support, like things like trauma-focused CBT. And a lot of these have been validated in this population and studied. Could be like medication management, or it could be working with both parents together as they come to terms about kind of with what's going on for their baby and for their family. I think there's a whole other lecture on parental psychological distress in the NICU and post-discharge from the NICU, and also the challenges of providing care in a setting where the parent is not the patient, and how do we do that in effective ways. Okay. So I've covered some of the importance of the NICU environment itself in the previous sections. This slide is just a reminder that a calm, noise-free NICU environment that protects sleep and encourages parental presence is very important to NICU infant mental health. I think some NICUs are more and more kind of moving from the open bay format to private room, which allows parents to be more easily at bedside and have more privacy, though there's again some debate on whether then there's a loss of some of the social support that parents used to get in the different format. But in general, thinking about kind of the larger environmental design of the NICUs is also really important. And finally, we cannot achieve any of these goals without working on providing a trauma-informed care. in the NICU. So what are the pillars of trauma-informed care? First is to recognize the widespread impacts of trauma and pathways to healing. Then we have to recognize the signs and symptoms of trauma in the NICU families, and importantly, in the NICU staff, right? A lot of times, like most of this talk so far has been on identifying various ways that we can support babies and their parents. And I do want to say that it's really equally important to support the NICU staff, as this is like a very high stress, high trauma work and can take an emotional toll, which then in turn kind of affects the NICU families. And once we recognize these, we need to fully integrate this knowledge into our policies, practices in the NICU, procedures in the NICU. So this could look like a lot of kind of, again, policies of like how to communicate with families, how to identify signs of trauma, how to provide support, what are the symptoms of trauma. Like, as you can imagine, this is like a very complex environment. And a lot of times anxiety and trauma can show themselves as like signs of agitation, or like kind of what we a lot of times think about as difficult parents or difficult patients, which then in turn kind of brings up negative attitudes or attributes from the NICU staff and might lead to re-traumatization of these parents. And so it's really important to actively try to resist re-traumatizing these parents. And the trauma is not just the trauma of having a baby in the NICU or like kind of medical vulnerability, but a lot of these parents come with a long history of various traumatic events in their life, which then affects how they're experiencing this current stress or traumatic event. This is a schematic that my colleagues and I, Dr. Scala and Dr. Shaw and I, came up with to show some of the main areas of psychological intervention in the NICU. It does not cover all of what I've talked about so far, but it does give you an idea that when thinking about mental health intervention or psychological interventions in the NICU, we do need to keep these different parts in mind. So the parental mental health, the infant mental health, and the developmental care interventions. And a lot of overlap exists between these different areas. And last but not least, I'm not going to go into detail about these, but I do want to mention that there are several formalized programs that have each used a combination of the elements we've discussed so far to improve things like parental sensitivity, awareness of infant cues, improve co-regulation, increase parental engagement in developmental care activities, and a lot of studies out there showing, some benefits and effects for like in different areas of parental mental health or attachment or child outcome for these interventions. Some of the difficulties that majority of these interventions need people to get trained in them and to kind of to be able to deliver them. And so that's not always possible in a lot of, as I think majority of our systems, we struggle with having enough resources and kind of time to be able to do this. And so that's kind of why when I think about promoting the infant mental health, like it's kind of breaking it down into things that then based on your NICU and the environment that you have, you can kind of choose and start working on some of these elements. Some of these interventions are kind of limited to sessions or kind of education or interventions while the family is in the NICU. Some of them start during the NICU admission and continue post-discharge. And this is some more of these formalized interventions. And to end this talk, I would like to thank the parent-child relationship programs at the Barnard Center, in particular, Dr. Monica Oxford and Maureen Gao. And I would like to thank all my patients. I've learned so much listening to them and working with them, and my mentors and all of you who have attended here today. Thank you. This is my email address. So anyone who wants to chat more or have other questions, feel free to reach out to me.